As you have already heard, renal cell carcinoma, has very high metastatic potential. The rate of solitary metastasis is quite low, doesn't exceed 11%, while the majority of patients have multiple metastases to 3 or more sites. Complete resection of solitary or limited number of multiple metastases can be curative or prolonged survival, and it is well established, and it could be due to combination of patient selection factors and surgical resection itself. Resection of symptomatic lesions may provide effective palliation to such sites as bone and brain and some other sites by relieving pain, preventing fractures, and improving patients' quality of life. In patients with partial response to systemic therapy, resection of residual metastases might provide a longer disease control. And last but not least, in patients with no evidence of disease, after complete resection of all metastases, discontinuation of systemic therapy may reduce its cost and avoid toxicity associated with targeted therapy. One of the largest metastasectomy series from Memorial Sloan Kettering showed that overall survival of 141 patients after curative metastasectomy was significantly better than after non-curative surgery and compared to patients who were treated conservatively. The factors independently predictive of survival in multivariate analysis included disease-free interval, more than 1 year, single-site metastatic foci, and complete metastasectomy. 5-year overall survival of 361 patients who underwent metastasectomy at my institution reached 37%, and female gender, disease-free interval more than 6 months, and again, complete metastasectomy were found to be the most significant prognostic factors. But when we looked only at pulmonary metastases, the only significant factor that influenced overall survival significantly was complete removal of all visible disease. Metastatic renal cell carcinoma of bone is often associated with disabling pain and mechanical failure of skeleton due to pathological fractures. Surgical excision may provide local control, pain relief, and improve function in most of the patients. Most prognostic factors are very similar to those reported in other trials and include solitary metastasis, large disease-free interval, achievement of disease-free status, and in patients with solitary metastasis, surgical excision provides 5-year overall survival which exceeds 50%. Different types of decompressive surgery with stabilization of involved vertebrae may be needed in patients with vertebral metastases to prevent serious complications and to control local disease. Most orthopedic surgeons advocate the widest excision as technically possible because achievement of free of disease status is the best chance for these patients to become long-term survivors. Patients with brain metastases are usually highly symptomatic. The prognosis is very poor with median overall survival around 4 to 10 months. It's been shown that the surgery or radiosurgery may provide improvement of survival and symptom relief. Palliative resection of unusual metastatic lesions may be required in some patients to relieve pain, improve function, and for cosmetic reasons, as in this case with large metastatic lesion. Targeted therapy provide better response in metastatic RCC, but complete responses are still rare. The rate of partial responses is much higher, but it's unknown if we have a partial response, what is left? Is it a viable tissue cancer or it's a necrosis? It's been demonstrated by FIRIC that that histologically active Ki67 positive renal cell cancer was present in 82% of resected metastatic specimens. Another retrospective trial, which included 22 patients with partial response, after targeted therapy, and which followed by removal of these residual lesions, showed that none of the patients achieved a pathologic complete response. This is just an example. One of my patients who received 21 cycles of TKI, followed by removal of, with partial response, followed by removal of these two retroperitoneal lesions. And as you can see, histology showed viable clear cell carcinoma with only some areas with partial necrosis. So I may conclude that surgical resection of residual metastases in patients with partial response to targeted therapy is indicated to achieve complete remission because of biologically active kidney cancer tissue. Another very important issue is whether we can achieve long-term free status by metastasectomy after targeted therapy. A group from MD Anderson retrospectively analyzed 22 patients from 3 centers who received at least one cycle of targeted therapy before resection of all visible disease. Surgery was safe, no deaths. 9 patients received targeted therapy post-operatively, and 50% of patients had no recurrence at a median of 43 weeks, which is not bad, and 21 of 22 were alive at a median follow-up of 109 weeks. In view of the fact that targeted therapy generally remains a palliative, long-term, continuous treatment, side effects, toxicity, quality of life, and high cost of the therapy is very important issues. It's unknown whether we can stop targeted therapy after achieving a complete response and re-administer targeted therapy in case of recurrence. 36 patients been evaluated, patients who, you've already seen this slide, the previous presentation. 36 patients achieved complete response either with targeted therapy alone or with targeted therapy followed by surgical residual metastasectomy. Recurrence was seen almost in all patients, in 2/3, 66%, but re-exposure to targeted therapy, what is very important from my point of view, was effective in 87% of cases. Every 3rd patient was recurrent-free at a median of 12 months, and median time of targeted therapy was 7 months. In multivariate analysis, none of the variables potentially predictive of survival was not associated with the time to recurrence or progression, including the type of achieving complete response, whether it was complete response achieved by targeted therapy alone or by combination of targeted therapy with surgery. Another trial, retrospective study of 64 patients, showed almost the same results. About 50% of patients had no recurrence at a median of 322 days after stopping targeted therapy, which is not bad at all. So we can conclude. Complete resection of solitary and limited number of multiple metastases can be curative and prolong survival. Metastasectomy can provide effective palliation for symptomatic metastatic disease to such sites as bone and brain and some other sites. Consolidative metastasectomy is feasible with acceptable morbidity. Significant time of targeted therapy and long-term tumor-free status are possible. And further molecular studies are needed to understand the heterogeneity in biologic behavior of metastatic RCC and the role of surgery in long-term cancer control. Several questions remain unanswered when treating a patient who is a potential candidate for metastasectomy, such as, is targeted therapy needed before metastasectomy? And if yes, what is the initial choice of agent? And what is the optimal treatment duration? Whether we should resume therapy postoperatively or not? And if yes, which the same agent or a new one? In the absence of prospective trials, we can only guess, and our guess is not always the case. Thank you very much.